Hi there, thanks very much for having us today. I'm just going to give you a bit of an insight into sort of like my journey in relation to wound care and surgery, honey. So as you can see, I'm 34 years of age, served with the British Army in between the years of 2006 and 2015. I was in the Yorkshire Regiment, part of the Brigade Reconnaissance Force Platoon. That's basically a unit which goes in behind enemy lines via parachute jumping generally, and obviously we go after the enemy. So I've done 2 operational tours of Afghanistan. I was based in the UK and also based in Cyprus. I was injured in January 2012 during the Brigade Reconnaissance Force training after coming back from Afghanistan. And I've obviously did that as part of an exercise for Operation Herrick 2016. So the injuries that I sustained were a complex open fracture to my left limb. I had 5 episodes of surgery in an attempt to stabilise the injury, but unfortunately all of them failed. I had in relation to plate screws, external fixation frame, like all in the result to try and keep my limb. Obviously, while this was happening, I developed chronic regional pain syndrome and also developed osteomyelitis, which was one of the main resulting reasons why I lost my limb, was due to infection. Medication that I had to take for that obviously played another massive part into the reason why I lost my limb, because I was on all different types of medication to control the chronic regional pain syndrome. That basically takes over your life, and it's impossible to sort of continue on through the day. As I'm sure you'll be aware, a lot of neuropathical painkillers really do, take over your life, and it's really hard to function with them. I was rehabilitated at Headley Court, an amazing medical centre that's run by the military, and obviously they tried their best in the years that I was there to get me to be able to keep my limb. And I was actually medically discharged with my limb, and obviously they thought I'd reached what they call maximum medical improvement, but unfortunately as life went on, my injuries got worse after leaving. Pain and sort of life changes, obviously, I'm just explaining there about the pain that I went through and obviously the life change that I've had since leaving the military, which obviously relate to me losing my limb. So the medical reasoning behind me losing my limb was more due to quality of life. So again, because of the medication that I was on and the fact that I kept getting osteomyelitis, even when I got a cold, I'd seem to, for some reason, contract that particular infection. And that was one of the main reasons why I did actually lose my limb, because the surgeons had said I'd been through 4 years of complex pain and infection, that they believed that that was obviously the only solution that was left for me. And I'm pleased to say that actually ever since I've lost my limb, my CRPS has subsided quite a lot. There was a worry that it would have transferred into my stump, but touch wood, it hasn't. So yeah, I'm quite pleased with the outcome, despite it is a major life-changing surgery. Well, after obviously having the operation, due to my infection problems that I had prior to losing my limb, I was introduced to Wound Care for Heroes. They're obviously a military veterans charity that look after your wound care. And I was told about this the day when I was leaving hospital, because there was a concern that when you go to your GP surgeries, that some of them don't understand complex wounds, and they can do things that necessarily aren't the best thing for your welfare. So I actually spoke to Claire, explained about my wounds and the fact that I was going to have dressing changes done. And she said to me, I want you to, when you go into GP surgeries, technically put me on loudspeaker and we'll talk through what he's going to do. The first thing that I noticed was the actual medical practitioner's personal hygiene wasn't particularly good. He had, dirty fingernails. The room we was going in was more like a storeroom cum medical facility. And obviously, due to losing my limb to infection, I obviously, didn't want him to continue on to remove my staples or anything like that. So I was referred to Wound Care for Heroes for that reason. So I had an initial consultation with Wound Care for Heroes. The main thing in relation to that is I was in control. So I told her what I did like and what I didn't like, obviously due to my chronic regional pain syndrome. And there was a whole host of treatment options given to me that works for myself, which was predominantly the surgery, honey. They offered family support to myself and my partner, Nicola. Obviously, because of the reasons with surgery, honey, being so easy to apply at home, rather than having to go into surgeries, my partner was able to do a lot of my treatments with the dressings. When I say like intervention and rapid referral, from the moment I went into the GP surgery to being back into hospital for obviously the staples removing and some cleaning procedures done, it was literally 48 hours. We have a saying in the military, flash to bang, which means basically from the moment something happens to receiving like an intervention, it was only 48 hours in relation to that, so that was very good. I don't think he would have got that on the NHS. Again, when I was in hospital post-surgery treatment, this is where Surgery Honey was introduced to myself. I had a consultation with Claire from Wound Care for Heroes. She mentioned to me that, you know, rather than doing, I think, is it called Carolex, what they did the wick with? Yeah, they mentioned that obviously because of my CRPS syndrome that I have, if they use Surgery Honey, it means that they can apply it to the dressing and put it into my womb, and then there's minimal sort of messing around after that. So for a CRPS sufferer, Surgery Honey is perfect because it means you don't have to faff around with the womb too much, and they can also use it as like a Steric-Clean as well. So around the actual womb site, I had a lot of tissue damage, and obviously my partner and Claire, they use it as like a cleanser as well, around my station to that. So we've put down there the setback. When I went to my limb centre, obviously their knowledge of Surgery Honey, they didn't know what it was. So when I turned up there with a sachet of Surgery Honey and a silicone dressing and explained to them what I'd been doing, they basically put it to one side and said to me, we don't use that here, we want to use a Pico dressing. And obviously when they put that Pico dressing on, it closed the womb area too fast and I ended up back in hospital again with another infection. So it shows you that Surgery Honey was working for me. And then another medical practitioner who wasn't aware of Surgery Honey just went back to something that they've always used, and it actually sent me back in time, unfortunately. So the solution was that I had to go back into hospital for another set of surgery and clean doing, and then obviously Wound Care for Heroes and Colonel Jeffries at Birmingham Hospital basically made sure that I didn't go back to the limb centre until I was fully healed. So as a summary, where I am now, I've obviously got my prosthetic limb on. What I think of Surgery Honey is that it's a dead simple product that you can be used at home for people's families. You don't need like a medical practitioner with you when you're using it. Availability of Surgery Honey doesn't seem to be widely recognised unless you ask for it. Obviously the GP surgeries up in Yorkshire don't, you know, they've never heard of it, so I think there's some awareness work to be done. And in relation to infection, we have another military saying which is first line of defence. So what I mean by that is that I think it should be ready available to people who are like paramedics, people involved in injury blasts within the military, because it could be put onto an infection site to stop infections from starting in the first place. So I do believe the product should be available to people like paramedics who deal with, you know, everything from blast injuries right through to just minor injuries from there. I think that's everything from me. Yeah, I'll hand you over to Claire.
Thank you. Thank you. I think the words of Einstein up there, where would we be without the bee? Well, we wouldn't actually be here. I want to personally thank Michael for coming and sharing his personal story. I now want to take you through how Wound Care for Heroes utilise some of the evidence that's actually been presented here this morning as part of the rationale for selecting Surgery Honey to utilise in Michael's case. And I think one of the key things to remember is that Michael has lost his limb to infection. His residual limb is then at risk and further infected. So we needed the most potent antimicrobial that we could get our hands on to actually give Michael the best chance of not losing any more of his residual limb, which ultimately would have affected his opportunity to have a prosthetic limb fitted in the future and whether he'd be able to walk on a prosthetic limb or not. So, you know, the decisions that we make at this stage in Michael's rehabilitation process are really critical to the rest of his life and his ability to rehabilitate. So I'll briefly tell you a little bit. I always use the opportunity to tell people a little bit about Wound Care for Heroes. But Wound Care for Heroes is a charitable organisation that has been developed to bridge the gap between military wound care management and transitional care into the NHS and lifelong care. You wouldn't be surprised to know that the patron of the charity is Simon Weston, who himself has had 35 years of ongoing surgery for scar management. So the things that Wound Care for Heroes will do are facilitate rapid referrals, get in the veteran to the right person in the right place at the right time. Had Michael gone through his normal process of going to the GP, being referred on, you're looking at weeks before he can get to see 2 military surgeons at RCDM, and we got him there within 48 hours. And everyone in this room knows how quickly infection can actually turn into something you don't have 6-8 weeks to play with. So we look after scar management, lymphatic management. We do a lot of complex wound treatments. We'll get people in for surgery. We also have triage pathways for prevention strategies. We keep veterans on radar for life. So someone like Michael now, who has been put into radar because he's now healed, having his rehabilitation, will soon be fitted with a prosthetic limb. And, you know, what we do for Michael now are studies to ensure that his residual limb is vascularised properly. He has had some issues where the residual limb has gone cold and blue, so it's about making sure that everything's okay for the future. I'm also fairly surprised at how many leg ulcers and pressure ulcers are actually referred to us as a charity. And it seems that if someone's a veteran, they will refer those types of wounds to us as well. So we still have a lot of preventative work to do in the future. We don't only look after Afghan injured, we don't only look after battlefield injuries, we will look after veterans who've had service-related injuries, and we will look after every conflict era. So across the nation, you can imagine just how many veterans will be on our caseload. So, as you can imagine, the military works really well. When patients are then discharged out of the military into the NHS, your initial referral back into the NHS is actually, quite transitional. What never used to happen was any notes come from here to here. So very often the NHS had a black hole in your notes so that it wouldn't find your MRI scans or, and in my personal GP notes, it looks like I haven't existed for a period of time because none of my military notes went across to the GP. When patients are here in the NHS, it's very difficult to get back to a military expert and you have to go through a certain pathway. So what Wound Care for Heroes does is facilitate that instant referral back to military surgeons and military experts. The even more difficult phase is when the NHS a patient's healed and you're discharged out of the NHS. What are you discharged out into? There was nothing in existence. So that again is where Wound Care for Heroes put in situ radar. We are now just about to embark on a King's College feasibility research study to develop the United Kingdom Central Bureau for Trauma Aftercare, because this also applies to civilian trauma as well as veterans trauma. So that's a bit about the charity. So what were we able to offer really to help support Michael? Well, first of all, a single point of contact. And I know for those of us, and many of us are touched by cancer in our families, but to have a card that gives you a name and a number, and that you can identify with someone. It doesn't matter whether you've got a simple question or you need to have an emergency referral into hospital. That gives you that sense of security that there's someone there. And I have to say, I think Michael's good testimony that that's worked quite a few times now, that he's able just to pick the phone up and say to us, I need help, this is happening, and we're able to intervene very quickly. I think the other important thing for Michael, and he did put it into his own slide set, was the fact that he felt he was out of control with his care. He felt there wasn't the element of trust. Anyone who's lost a limb to infection is going to be absolutely terrified of getting another infection. And some of the points that he touched on about cleanliness, and I feel us as nurses, we need to actually, perhaps overemphasise some of that to patients similar to Michael. I think also Nicola Michael's partner. I've never met her face-to-face. I've only ever met her on FaceTime. And we used to FaceTime at 9 o'clock at night, 11 o'clock at night, Sunday mornings. This was happening November, December, January. So it's like, Happy Christmas, Happy New Year. What was brilliant about the use of Surgery Honey is that Nicola found it so easy. She literally was directed over FaceTime how to do these dressing changes. The military burns specialist team over at QE had written out some instructions that Michael had taken back, and then we actually conducted everything over FaceTime. And I think for the future, and where more partners and carers get involved in wound management in the community, this is a really key factor that's very easy. I know we're going to look at more formats later on in the programme, but in its current state, it has been very, very easy to use. So I've already talked about rapid referrals. So our CDM specialist nurses there originally he'd been having Aquacel AG on his wound, and it was totally ineffective. And Curlex that Michael has mentioned has in the Burns Plastics Military Unit been one of the products that they use. It's like a stringy gauze that's impregnated. That, and I've got some pictures to show you, was a bit problematic when teamed with chronic pain syndrome and fibres that were stuck there. So it was very evident that we needed to actually change that. But I want to give you the rationale. I'd been very fortunate to be working very closely with both Matoki and H&R, who are distributing Surgery Honey. So, of course, I'd been exposed to consultant orthopaedic surgeons in Cardiff who had used Surgery Honey intraoperatively to prevent biofilm formation on knee revisions and had actually closed up the wound. So I've got all of this in my head. I'd also been very fortunate to have spent time with Fenella Halstead and Beryl Oppenheim, so I was very aware of all the work going on there, and very aware of all the wonderful work that Matthew and Jonathan Cook had been doing. So I've got all of this work in my head, and I know that this is the right product to move forward. How we utilise the product. So actually, when Michael had a lot of his cultures done, we had a lot of negative results come back, but we know that we had a lot of positive staff results. So based on work that you've all seen today, it's very evident the reason why Surgery Honey became the best option for us. But one of the reasons that we also opted to use it, and I know there's been discussions today about the dilution and diluting it down, but actually we did use also a diluted version to use as a peri-wound cleanser. And, you know, the Halstead work shows that it was the most potent at the lowest concentrations. And actually, you know, I think Michael's case says it all, that I believe the combination of us using it as a diluted format, as a peri-wound cleanser, and using it in its neat, Surgery Honey 1 in its neat format directly onto the wound, and we had the most fantastic results. And I've explained why it actually came out favourably to Aquacel. So we knew that it was going to be a more superior antimicrobial than what Michael had already actually received. So Michael was only 3 to 4 weeks post-amputation when he had this episode where he'd got staples, he'd got deep tissue abscess, he was at risk of developing osteomyelitis again. He's already talked to you about his chronic pain syndrome, and literally by just opening a staple remover, Michael would hit the ceiling with pain. I could be this far away from him. So again, it's about the NHS staff recognising that that wasn't something that they could do. Michael was rapidly referred into our CDM, and he did have to go to theatre, be anaesthetised for staple removal, opening and evacuation of that wound. So here you can see some of the pictures. This was the very first image that I received from Michael when I don't think we'd actually spoke. I think I just literally got a message come through with, is this normal? But here you can actually see staples had been removed. This had been opened up. I don't know whether you'll see from there, but you can see where the specialist team have put in lots of curlex here, and we had great difficulty actually getting some of those long stringy fibres out. Here you can actually see where surgery honey has been utilised on the wound, and we are now starting to get rid of all of the devitalised tissue there, and the wound was starting to heal up nicely. You'll see on the next slide actually how this progressed just over a few days to the fact where we're now 2 weeks and we've gone from having deep tissue abscess to, you can just see the residue of surgery honey around there, but actually we're closing actually beautifully, and this is the point where we referred back to the rehabilitation unit. Everything's going great. Michael's almost healed. Michael's off to rehabilitation. Happy days. So Claire's on the M5 one day and phone rings and it's Michael, and it's like, oh Claire, I've just been to rehab and I thought I'd better let you know they've stopped the surgery honey, they've put the pico on. And, I'm staying really calm on the phone. But actually, if he'd have seen me behind the wheel, I was probably going, rah! But as a result of removing the surgery honey and applying the pico, closing off that wound, you can actually see we went back to square one. So I had to initiate another rapid referral into the colonels over at RCDM. He had again developed deep tissue necrosis and abscesses. He went for surgery. The option this time was made not to repeat referral back to rehabilitation. We actually opted for closed pulse irrigation and the KCI vac. The dressing was changed at 3 days and 6 days, and then he was taken back to theatre for surgical closure of the wound. And you can see there that's closed pulse irrigation in situ. This is day 1 after surgical wound closure. And here you can actually see, although he's got this is actually one of the pictures that Michael sent to me. Claire, does my limb look a bit purple, isn't it? So as you can see, scar line, limb now healed. He's now on op radar. We have referred for angio studies, and he's hoping to be fitted with a new limb very shortly. But in summary, I actually feel that surgery honey reactive oxygen proved to be a more effective and a more potent antimicrobial, and particularly if you look at episode 1 of this treatment. Based on current lab work, and we've all seen that today, I think as we're starting to use closed pulse irrigation more, I think that we ought to start looking at, can it be used as an inclusion for closed pulse irrigation in a diluted format? And I think there's room for research there in trauma orthopedics and other areas that are using closed pulse irrigation. But I certainly know that both myself and Michael have been really pleased with the results that we've seen from surgery honey today. Thank you.